If anyone else you wanted to bring up here,
Just me.
just that's fine. So we're back. This is Senate Health and Welfare. It's still January 22nd. And we're moving on from the Green Mountain Care Board testimony to emergency medical services. And we have the chair of the Vermont EMS Advisory Committee with us. Well, first of all, introduce ourselves, Drew, because you may not know everyone. Go ahead, Senator.
Senator Larry Hart, Orange County.
Senator Sam Bozeman, Orleans.
Judy Lyons, Chittenden Southeast.
Martine Laurent-Bueller, Chittenden Central.
So, and Senator Cummings will come in. She's from this area. That's great. Well, thank you for being here. And we're just looking for an update on where you are with the advisory committee and maybe an update on what happened last year and how that's affected EMS services around the state, in particular your area. So.
Excellent. So Drew Hazelton, I am the Chief Operations Talent Rescue Inc. in the southern part of the state, down Broward, Townsend area. And I also do chair the EMS Advisory Committee. If it doesn't know, just new people in the room. I've worked as a paramedic for about 30 years. So I still work in the field, taking care of patients as well as, managing an ambulance service and doing some of the advisory stuff. So last year we did have some EMS specific legislation that has kind of paved the way for us to really get an understanding of what's going on in EMS. So the major part of what was passed last year was towards an assessment of our current EMS system and the development of a 5-year EMS plan based on what we've learned. So I've sat in this chair quite a few times over the years. And some of the challenges that we've been facing in EMS is that we just don't know certain pieces of information. So, and this is our second attempt to get information about what our EMS system is and what our EMS system needs. So people would think it's pretty straightforward to understand what it costs to deliver EMS or what our workforce needs are. But EMS is different than a lot of other services because it's delivered in many different ways depending on who you go to. So in some areas it's a municipal run service. Some areas it's a combined with a fire service. Some areas it's a standalone nonprofit. We have regional nonprofit, we have for-profits, and so it's very difficult to compare that information. So the legislation last year allowed the advisory committee to spend up to $150,000 on an assessment. So we have hired a consultant who has started gathering data, and hopefully we'll be able to come up with a way to compare that information so that we can really see what the cost of EMS is across the state and what the workforce needs. So the 3 areas that we're looking at are workforce, cost, and reliability. So we tasked that with measuring not just whether ambulances show up or not. So that's certainly one aspect of the reliability, but we're also looking at some national clinical quality standards to see whether our EMS system is meeting those needs. That work, that initial work is due to be done by the 15th of April of this year. We're due to report that back to you by next December. And the legislation called for us to develop a 5-year statewide EMS plan by December of 2026. A couple other things that were part of that was a requirement to coordinate our work with the Public Safety Dispatch Committee. What's the official term of the task force?
Which one?
The Public Safety Communications Task Force.
That's good enough.
Good enough.
Right. I don't remember either.
Yeah, the one is looking at the 911 dispatcher.
That's right. And it used to be Claire O'Neill, but now it's someone else. I've lost track.
So, so we're not looking at the dispatching components of EMS because you already have another group. So we're working with them to get the information that they've already gathered.
E911.
Yeah, that piece of it, and it certainly plays a big role in what we're doing. What I can tell you for certain is that our current system does not meet our current needs. So we're hopeful that as a,
Sorry. It seems that that is the refrain across almost every system in the state right now. Yes.
Doesn't meet our needs. Right.
so, and the system that we have was built to support the EMS of the 1970s. So, so a quick history lesson, EMS kind of became a thing in the late 60s as highway traffic deaths increased and people were dying on the streets around the country. That's where EMS came from. And it started as in most areas, as a transportation model that was being done through the local funeral homes. That is not the system of care that we currently have.
I didn't realize it started that way. Wow. Yeah.
And there's a lot of areas where the private EMS services that still exist around the country are still actually owned and operated by funeral homes. And that's where most of it started back in the 60s. And it's evolved, and EMS now is healthcare. And most people don't think about EMS until they're having some sort of healthcare event. But when you do think about it, what are you really looking for? You're not really looking for Uber. You're looking for someone to come to your house that can actually provide life-saving care. What we have in ambulances here in Vermont now is very different than what we did then. And so, for example, part of our healthcare system is transportation. And I'm sure I stuck in last week for a minute and listened to the Hospital Association talk, and I think their number 2 priority maybe was EMS transportation between facilities. And the reason for that is as the patient's acuity increases, many of our local hospitals need to refer those patients off to specialty centers around the state. And I can tell you in our world, we take most of our patients far away. Due to hospital capacity, we're sending most of our patients now to Southern Connecticut, Boston. We've been as far as Buffalo, New York, and up into Portland, Maine, because there's no bed capacity around us. So the EMS agencies that are providing services now have to be able to provide the same level as your ICU, because we're moving those patients to and from ICU. So it's very different. So we're coordinating with the Communications Task Force. We have met with the Green Mountain Care Board. They're now going to be attending our meetings and helping to maybe coordinate the work that they're doing. We haven't identified a clear intersection with what their current plans are, with what we're working on, but we're certainly going to continue working with them. The one place that we have not been able to really work with yet is the regional and county government.
The regional planning commissions.
No, it's a study committee that was created
Oh,
last
the
year.
study committee for county, yeah.
So that committee we started reaching out to, and they said they needed a little bit more time to kind of establish themselves before we could start working with them on that.
Yeah, that's a really good idea.
So those are the kind of the major components of the study that we're underway. We're gathering that data with a timeline of April. Another component that changed was an increase to the EMS special fund, which is used for EMS education. The state for the last 13 years has invested $150,000 a year statewide in supporting our EMS system. Last year, that was increased to $450,000. That's a surcharge on insurance companies that goes into a special fund. Out of that money, we were granted the ability to spend $150,000 towards the study work that we're doing, with up to $370,000 this year being able to be used to complete that study work. It is likely that we're going to need to come back for the end of the session and ask to extend that timeline, because I don't think we're going to be able to get the contracts in place quick enough to hire the contractors through the end of the year. It took us, with the help of the health department, until the middle of December to get our contractor hired. The contracting process, the health department is very slow. So we're thinking that the next phase of our project, we're probably going to suffer from the same timeline, and we'll probably run out of a year before we get that contractor hired. But I'll come back and give you more on that as it develops this year. with the special fund, everybody that remembers the conversation, the EMS special fund has been very difficult for services to access over the years. There have been many years with the 13 EMS districts, a handful, sometimes as low as 3, were able to jump through the paperwork hoops in order to get the grant funding. So for many years, that $150,000 was not actually spent, and it built up over a period of years. So during the last 5 years, we've come up with ways to get the money out. We have now a new distribution method that the health department worked up, that the advisory committee voted to support at our last meeting last week. So we're moving forward with I think a pretty solid plan to get those dollars out, as opposed to kind of sitting in a fund of the health department where we maybe get the money. So that's the update on what we did with the latest. Oh, one piece, I'm sorry. The other piece was a change in the treat no transport to require Medicaid to pay the BLS rate. Unfortunately, the interpretation of that, when it went through the Medicaid and decided to pay the transfer rate, not the actual emergency rate. So
What's the difference?
it's about half the reimbursement of what the emergency rate is. So we get paid, kind of back up again here. Ambulance services really only have a couple of billing codes that are allowed. And so we have a BLS emergency and ALS emergency. We call it ALS 2 emergency, which is a really sick patient, or we have a BLS non-emergency or an ALS non-emergency. Those are the allowable bills. So all of the folks in the EMS world were under the assumption that the treat no transport, which came in as an emergency call, which involved us getting people out of bed, sending them to the house, would be paid at the emergency, not the hospital code. And so that was a thing that came out of it, and unfortunately disappointed a lot of services because they received half the revenue they were expecting, because we're getting paid at that hospital rate, not the emergency rate. So that was the other piece of that.
So that's a decision that's made by the Department of Health or DEVA.
DEVA, so the legislation was clear that it needed to be paid at the BLS rate. And they took the BLS non-emergency rate versus the BLS emergency rate. So I think it was a intent question more so than the legislation said BLS rate, and there are 2 BLS rates. They just happen to be one for hospital to hospital and one for emergencies. Small challenges. In case you're, sitting here talking to hospitals about transportation needs moving from place to place, one of the reasons why hospital transportation, getting patients from one facility to the next, is difficult is because a BLS transport from one hospital to the next quite often is costing the ambulance service money because it pays at such a low rate. So, for example, in our system, we work closely with the Brattleboro Retreat, and we've had a program now for 2 years to help get patients that are being admitted to the retreat from hospitals down from wherever they are, St. Albans or Burlington, down to the retreat. And the reason for that is because those patients, those calls are billed at the BLS non-emergency rate. Doesn't actually cover the fuel to get from Burlington to Brattleboro. So we have a program with the retreat that allows us to go get them and bring them back to the retreat, so they're not stuck in emergency rooms. And a lot of that is the structure around the way that those are reimbursed.
We have a question.
Sure.
When you guys transport for instance, to the Winter River Junction VA, do they pay you? Because I know that they paid for my dad to be transported 100%.
So VA is complicated. So it depends on who the provider is and whether you have the appropriate agreements with the VA. So services that are close or transport a lot of VA patients can quite often get through the hoops to be paid by the VA. Some of the other services are not, because it is complicated to get through the VA process. But, there has been some federal legislation recently that has helped with VA payments. But we're still on the federal side working to try to streamline the federal VA stuff.
I know that they had Upper Valley Services out of Fairleigh transport my dad to the hospital and to back home on the Friday. He passed away on Monday, but they brought because he wanted to be home to nature do his thing. But yeah, they paid 100% of that. I know they were paid 100%.
Yeah, so Upper Valley is the one service that actually has a contract in Vermont with the VA. So if we had done that transport, we would not have gotten paid. We did them anyway, but
So going back to your, to the report that you're working on and the sort of the plan. Will these issues, payment issues be included in that in terms of contract relationships and how to improve?
those will be
Okay.
part of the plan. So this year, historically, we've had a report that was due to you. We did not this year because of the cycle and that we're doing the work. But we did upload a letter that explains what I just said that you guys should have. In case you want to reference that, but we did not put a report out. The next report won't be due until the fall, and that will be just the assessment. We're hoping that if we can get our next contractor hired, that we may be able to give you some preliminary plan information before the start of next year. But we're still working on kind of that timeline, and then when we get the people in to help us with the data analysis.
How many are on the advisory committee? How many people are doing the work?
That's a good question. 14, 16?
Yeah, so it's a big group. Yeah. All right. Other questions? And I do have one more at least, but just other questions. So the big report will be here December 26th.
Hopefully before.
Yeah, it would be nice. And it'd be good to see kind of the interim draft thinking, because it helps us get started ahead of time. So obviously we all hear from our EMS folks all the time, and they're really critically important to our towns, our municipalities. And some, as you said, some municipalities pay for them and some are totally volunteer, but you all have specific requirements you have to meet to be good, to be at EMS folks. I have heard about the provider tax from one community, and how that it is too much. And then I've heard about, and I'll let you explain the provider tax as you know it.
Mhm.
But then the other one is a request for more ambulances, and that municipalities can't afford how can we help with that? And I don't know whether that's going to be part of your plan as well.
So
Let's start with the provider tax.
provider tax. So we gotta go back about 10 years and talk about the provider tax. So where this came from is Medicaid in Vermont had not changed its payment for EMS. So Medicaid payments for ambulance service, and I think a lot of things are not tied to automatic increases. So it had been about like 15 or 18 years since EMS had seen any sort of increase in the reimbursement. And at the time, the only real way to see increases in our Medicaid payments was through the provider tax. So we met as a state association. We looked at kind of the pros and the cons of the provider tax. And what it was set at was at 3.3% of net patient revenues, which was intended to generate about $1 million in tax to draw down what was supposed to be 2.2
It's a match
something.
with a federal match.
Federal match.
Yeah.
And that money was put back into the system in order to bring our Medicaid payments, which were at like 34% of the Medicare at the time, up to 80% of the Medicare at the time. So the catch being those communities that did not have a large percentage of Medicaid patients paid in more than they got out. Those areas that had more Medicaid patients made out better as far as what went in versus what came out. So Since then, we've once come back and been successful at getting our rates increased. Again, it's been, I think we're 4 years since the last Medicaid increase for ambulance services. The provider check tax has not changed. So we are now paid as far as percentage of Medicare less, but we're still paying the same tax. So and I guess the way you look at it is because Medicare now pays us a little bit more, then we're paying more, that's net patient revenues in the tax, but we're not seeing an increase on the Medicaid side, like we did before. So right now the provider tax is generating about 1.1 million. So we increased the state revenue by about 10% just because of the increased rates on the commercial and on the Medicare. But again, we haven't seen much movement in the Medicaid rates. If you're interested, so New Hampshire is doing something very similar to what we are. They just happen to be a little bit ahead of us. They did a cost report on the delivery of ambulance service. Theirs was done through the Department of Financial Regulation. Their report came out last week on what it costs to deliver ambulance service in New Hampshire, which is, I'm guessing, going to be very similar in cost to what we've come up with. And what their data shows is that in order for ambulance service to be viable in the state of New Hampshire, all payers need to be paying 202% of the current Medicare fee schedule. So, again, I don't want to say that's what I
Reference base, right? Yeah, that's helpful. If you have that report,
I do. I can send it to
can
you.
you send it to
Yep.
Kiki?
Yep.
All right, we'll
So
look at it.
they're a bit ahead of us, and like I said, I'm
Well, it's just this will be part of the work that you're doing with the, your advisory committee. Okay. So one last question for you, because we need to move. Well, this is really great. This is a good way for us to get a beginning look at EMS. And I know that, when you give your advice, who do you give your advice to as an advisory committee? Are you advisory to the Department of Health or, and to the legislature? How does that work?
So by statute, we advise the commissioner and the two committees of jurisdiction, government operations and healthcare on both sides. So we're advisory to you. So, and we have met with the commissioner as well.
Right.
In fact, we did do
Terrific.
if you have any questions at all that come up that as we're discussing, please reach out and I'll be glad to answer.
We will, and as we start going through the session, it will be important to hear from you, your recommendations for what we can do to help keep the process moving forward. So I think most of us have some connection with our local folks, and we don't want to lose them. And we know transportation is such a key right now in the whole healthcare reform discussion. It's important to have you here.
So I will say that, we're doing a very comprehensive report, and I'm really excited about the outcome of our plan. But it is important that you guys still recognize that the challenges that EMS is facing have not gone away just because we're doing the study. We have a lot of areas of the state where workforce is preventing reliable EMS. We can't quantify that for you yet because we haven't done the study. We know that to be true because we live it every day. So soon we'll have data to show you exactly where those spots are. But we know they're there. And we know that there's some areas of the state that are struggling more than others.
And Drew, we say workforce, does that include volunteers?
Yes,
Yeah.
Okay, but you're also talking paid staff,
correct.
both.
Both. Yeah, we have a lack of, services are struggling to get not only volunteers, which makes up a lot of our statewide workforce, but even career personnel are difficult to find. Many, are seeing vacancies. I know in our area, we're losing a lot of, we live on a border, so we're losing a lot of talent out of state. That continues to be a challenge for us. So we're,
Better pay, better working conditions.
better pay is it. And, we've been working at trying to build in-state education programs. So one of the challenges we've had for a long time is that our paramedic students leave the state, get their education, and never come back. Because when you do paramedic education, there's a significant amount of internship that you have to do. And if you go to Maine and you do that work, or you go to Connecticut and you do that work, quite often they get picked up by the services that they're doing a ride time with. So one of the areas that we've been focusing on is trying to build in-state capacity so that we can keep our talent here. Maybe we need to, chain them to our ambulances or something. But back to your question about ambulances, so we've seen an increase in cost. So when town can tell you about the cost of ambulances, the cost of ambulances has gone up 50-60% in the last 2 years. So
Just the
ambulance itself.
Wow.
Yeah, the cost of equipping an ambulance now. So the stretcher assembly in the back of a modern ambulance now is almost $50,000. So when people are coming to their town meetings and saying, hey, this fully equipped ambulance is going to cost us $350,000, like they're not making it up. Like this is like the cost of I don't know why, but it's gone through the roof. I have 2 ambulances on order still that I ordered in 2021 that I haven't seen yet.
Oh, wow.
So
Now you need to order more.
yeah, so we're holding on to, like, we're trying to keep trucks on the road that we should have retired because the ambulances we ordered, and we thought we were ahead of the curve, right? We ordered them a year before we needed them.
So our town has a contract with East Barry. And I think we pay them $78,000 a year for the contract. I had one medical emergency where my grandfather tripped with a shotgun and shot his granddaughter in the hip. Came to my house, I called 911. 18 minutes later, they were in my driveway as I'm protecting the wound and stopping the bleeding. After I pulled the wad out of the shotgun.
Oh, gosh.
So I knew what I was doing. I was a Marine, so I was doing that. But yeah, 18 minutes from the time he's buried in Thompson, they were there.
There's a lot of places in the state that is not going to be the case. I had one last week where we were the 7th ambulance service that they tried to call because the first 6 didn't show up. And then when they finally got to us, it took our ambulance 58 minutes of drive time to get there. So the 911 call till when we arrived was well over an hour and a half. Because again, they tried 6 ambulance services before they called us. And with our drive time of 58 minutes.
Wow.
So, when I say like, we still have challenges.
Oh, yeah.
Yes,
We still have
huge
challenges.
challenges.
But we're trying to get you good data so you can make good decisions.
Well, thank you. And thank you for your work. We always appreciate what you do and enjoy having you come in and help us understand what we need to do to help things move forward. So
Thank you.
Thank you.
Thank you.
We'll see you again, I know. And so before we move on to John Soroyan, who is probably out in the hallway. When I get him.
Sure.
Yeah, I just wanted to let the committee know that we have some Middlebury College students here. They're taking Jessica Holmes' class at Middlebury. And we know Jessica very well because she is on the Green Mountain Care Board. We rely on her for good data and information. So do you see all of you who are Middlebury College students, would you please introduce yourselves to us as Dr. Soroyan gets set up for his presentation. So we'll start with you.
Hi everyone, my name is Jasmine Wang and I'm a senior at Middlebury College where I study mathematics.
Hi, my name is Maddie and I'm a sophomore and I'm majoring in economics and poli-sci.
Hello, I'm Ananya Molpur. I'm a junior student at Middlebury College, studying political science, hoping to become a healthcare and national security lawyer.
Excellent.
Hi everyone, my name is Maren. I'm also a senior and I'm a BCom major and a business minor.
I don't go to Middlebury.
But you're here.
I'm here from UVM. I work for Planned Parenthood of Northern New England.
Oh, good, we're glad you're here. Thank you. Okay. So I think you'll enjoy the next part of our meeting, which is about the blueprint and our primary care program we have in the state. Do you, Dr. Soroyan, would you like to have your teammate up here with you, or?
We can swap. It's okay. That's what we
Okay,
did last year,
we're
so.
good. And you have, is Addie Stromolo also on the line?
Dr. Armstrong, Adam Armstrong, I don't think
Okay.
Deputy Commissioner Strong is here.
Oh, Addie Armstrong. I completely read the name.
No, it's just that I think you.
I'm not quite that far.
We get each other's,
Online. How frequently do you have two people saying that?
Especially this one. It's
Yeah.
quite rare.
Yeah, sorry.
If
Sorry
Alex
about
leaves,
that.
we're
Dr.
good. Sorry,
No
Alex.
problem.
I'm counting. We're at 16 for her math. Thank you.
Okay,
Yeah, 16 in this.
everything okay?
Everything is good now.
All right.
Counting PM. I didn't realize that we couldn't have chairs on.
16, no, that's it, no table. So, thank you for being here, and we are going to introduce ourselves because this is the first time you've been here with our new members, so we'll start over here with Senator.
Senator Larry Hart from Orange County.
Nice to meet you.
Sam Bozeman, Orleans County.
Ginny Lyons.
Martina Larocque, Chittenden Central. And Cummings, Washington, just right here.
And I'm John Soroyan, the Executive Director for Blueprint for Health. The Executive Director, my colleague, Dr. Addie Armstrong, on my right, the Health Services Researcher for Blueprint for Health. And we're going to give an overview of the blueprint, Madam Chair, and also a update on the expansion investment that we've been doing. So please, the audience.
So we have this online, we've got Blueprint 101 and then the expansions, or just the expansion.
Yes, and I have my 101 slides within it. I also, with my team, submitted documents with definitions of terms and just added glossary. Kiki was kind enough to upload that. Thank you, Kiki. And I also submitted a document in testimony supporting the initiatives we do, both from our own past evaluations and from evaluations from the public health and medical literature. So those are for your perusal if it's possible. But want to make sure these are rigorous presentations, and I know Senator Lyons always appreciates that academic evaluative bent. And I'm going to remind myself how to advance in Zoom. I think I tapped. Yes, the Blueprint for Health started in 2011 statewide to promote high quality primary care and focuses on building best practices and prevention services into primary care as well as specialty care. It's founded on the principle of patient-centered medical homes and in Vermont, multidisciplinary community health teams, which I'll be focusing on more in the slides ahead. Community health teams provide care coordination, and links with patient services at no additional charge to the patient or family receiving those services and with no specific claim to their insurer. So those services are regardless of insurance and available to patients who are seen in those practices. Notably, Medicare, our federal payer, Medicaid, the state, and 3 commercial insurers make payments to support the initiative. So this has been a program with that funding knitted together. The Blueprint for Health has built upon these initial 2 foundations of patient-centered medical homes and community health teams with the hub and spoke system. The hub and spoke system for opioid use disorder is overseen in partnership with the Department of Health. The hubs are usually for opioid treatment programs for methadone, and the spoke system of care is integrated opioid use disorder treatment within primary care, so people can get their prescriptions where they usually go to the doctor for if they've got an opioid addiction. The Pregnancy Intention Initiative was also a new initiative, and that provides access to services that support pregnancy intention. And that also is within primary care, within specialty care, and partnering with Planned Parenthood of Northern New England. New in 2023, and Senator Lyons is very much at the center of this, in my view, is the expansion of our community health team pilot, which aims to build on our successes by creating more capacity to meet the mental health needs of our population, meet the substance use needs beyond just opioid use disorder of our population, and really address things like difficulty with transportation, difficulty with housing, difficulty with financing, what's called the social drivers of health, which we know I didn't learn about in medical school. But if you don't have transportation and you don't have finances and you can't feed your loved ones, you're going to have a lot of health problems and end up with medical problems. The pilot in 2023 created significant funds and appropriation to expand the community health teams. This is a 2-year pilot. The pilot ends June 30th. I did. Yes, and specifically, we're getting that support as close to patients as possible by placing additional team members in primary care practices. They're also within the expansion in partnership with the Department of Health is a program specifically for infants called Dulce, and I've included a description of that in my glossary. So funding also came for those family specialists through the expansion pilot. We've also got a significant number of educational opportunities for providers and team members that were new, and a big investment in our quality improvement facilitation to improve everybody who walks in the door answering questions about things not related to necessarily their chief complaint or the visit, but things related to their mental health, any history of substances that they are having difficulty with, as well as the other factors, as I said, the social drivers of health. The educational opportunities are all on our website and have been very well attended. They include a CARE series, everything with an acronym. I know now. This is actually in partnership with the Center for Technology and Behavioral Health at Dartmouth College, and these are monthly webinars open to all that have gone beyond our previous offerings around opioid use disorder to alcohol use disorder to ADHD to psychostimulant disorder, like to really expand our educational offerings for our audiences so that they're getting their continuing education units, but they're also getting the latest practice. We had a very well attended in-person conference in June of 2024, as Senator Lyons will probably remember, and we'll be having another in-person conference across the way, I hope, in Montpelier in June again this year. Motivational interviewing, I won't go into, but this is a method of speaking to patients in a way that gets them going with their own goals. Links to really move people out of poverty, a program called Bridges Out of Poverty, as well as other programs related to community health work training, the Pride Center, and lots of training for pediatrics. Dr. Armstrong is going to take over Senator Lyons, if that's okay, because we really wanted to give you some time about
You're in
Uh,
this.
charge.
And I know Susan's coming at 11:45 if she's not already here, so we'll stay on time for you.
You're fine.
So for those of you who don't know who I am, I'm Addie Armstrong. I have a PhD in math. My background is as an operations research analyst, and I'm now the Women's Health Services researcher. So I'm here to tell you a lot about quantitative stuff. How many, how much, what are we doing? So first off, who's participating? There are 128 blueprint practices that are active in the state right now, and 93%, roughly 92.9, are participating in the expansion. Why are some of them not? Some of them just opted out. We had a few who opted out because they planned to retire, and they're saying, well, I'm going to be done this year or next year. I don't want to opt in and hire these people and then get rid of them. Some of them opted out because it didn't fit. They didn't have space to embed more staff, things like that. A couple of them started after the expansion started, and they never had the chance to opt in because we do have to have deadlines on when we send checks. So there are things like that that are contributing. What happens when a practice says, I want to participate? They receive additional funding for CHT staff, and we ask that the practices put those staff in their office with them wherever possible. There are some places that are very small that's not possible. Maybe they're, down the street a little ways, something like that. The practices also agreed to implement screenings.
Very quickly, can you share who might be that staff who is on the community health team?
Of course.
What are their?
Yeah. So community health team members can range from a licensed mental health counselor, a licensed drug and alcohol counselor, a community health worker. Community health worker is kind of sounds like a broad category, but usually it's someone who has lived experience in the community, and they might be connecting people with resources like food stamps. They might have had a substance use disorder and they're recovering from it, and they're serving as a recovery coach for someone. So they're, lived experience people. We also allowed practices to hire care coordinators or care managers, who are people who help set goals or help you set up, 10 appointments because you have a very highly complex condition, and juggling all these doctors and appointments is complicated. So those were the three primary types that the expansion focused on. Community health teams in general also can include people like nutritionists, diabetes educators, health coaches, all sorts of social workers, all sorts of people of all sorts of varieties. But we focused on those three types to try to really target the substance use, mental health, and social drivers of health. All right.
That's what I do.
So you know exactly what we're hiring. Wonderful.
Well, I lost a daughter to opiates, so I couldn't save her, but I could help save other people. So that's my.
That's what we want to do. Very, very worthy. And the practices also agreed to implement screenings in the areas that Dr. Soraya talked about. So, do you smoke? Have you ever used drugs or alcohol? How do you find it getting to places you need to go? Screenings are questions like that people ask and answer. And that is, so doing pretty good. 93% of our practices are participating. They're working on it. What is the impact? What has we seen? So first off, let's start with some numbers. CHT patient counts by quarter. So every quarter, we ask all of our health service areas to report how many patients did your CHT see, community health team. And you can see here, this graph, the dark blue, before quarter 3 of 2023 is before the expansion. Quarter 3 of 2023, I highlighted in bright green because that's when it started. It started right in the middle of that quarter, so it doesn't really belong in either side, and it takes time to hire people, so it really doesn't belong on either side. And then the light blue going forward is after the expansion. And you can see we've really gone from hovering around the 20,000 patient mark to hovering around the 26,000 patient mark. We can't increase forever, naturally, but we can increase quite a bit, and we did. And the other thing, there's two more things that I want to note here. The rate of increase of the patients, so kind of the steepness of the line from the beginning to the end, has also increased. We're not just seeing more patients, we have an increase in how quickly we're seeing more patients. And there's a third thing that is fun to observe. The average number of visits, and when we say a visit, I mean an interaction, and not just I called you and reminded you your appointment is tomorrow. I called you and had a conversation about a condition you're experiencing. I made a referral and got you in touch with these people. We all three sat down at the table. That has gone up from about 2.9 in 2023 to about 3.9 in 2024. So we're seeing more patients more often, and that's great news. So we really are seeing a lot of impact that way. Who are we serving? You know how many? By insurance type, everyone. No one is excluded from the expansion services provided or from the community health team services provided. So this is as of quarter 3, 2024. Quarter 4 numbers aren't fully in yet, so I can't talk about those yet. But it's about 30% in all of the major categories and about 11% in what I call the other category. So Medicaid, Medicare. Commercial means for us, Blue Cross Blue Shield, Cigna, and MVP. Those are the 3 major commercial insurers in Vermont. There are other insurers, they are smaller. Humana is a smaller insurer. They would fall into that other list. Other would also include VA insurance. It might include people with no insurance at all. It might include people with out-of-state Medicaid. So there are people in that category. It's not trivial, but we just see about equally distribution. And this is about what we would expect based on the percentage of people in Vermont who have each of these types of insurance. So it looks like we're serving everyone approximately the proportions we expect, which is a good thing. So who did we hire? What did we do? We have And I say Blueprint Practices, have hired 102 individuals in the roles that we were talking about earlier. That's 62.8 full-time equivalent positions. So a full-time equivalent position is 40 hours a week. Some people work half-time. Some of these roles, as members who have experienced this know, are better done in half-time because it's a high-touch role. It's a very emotionally invested role. And sometimes it's easier to do that 20 hours a week than it is to do it 40 hours a week. So about
Addie, this is like phenomenal. How rapidly this has happened. Senator Lyons, in less than a year and a half since this money started being dispersed in August of 23. The work that our partners have done across the state to fill these positions is creative, innovative, and just right on target. And Addie's like showing the numbers. There was a lot of skepticism about whether the Blueprint would be able to create these positions because we didn't know if we'd be able to fill them. And thank you, Addie. I don't mean to interrupt you, but I just want to say kind of the macro of this. It's phenomenal.
Yes. Yeah, we all know how hard it is to see, signs on banks, and you can't get into your McDonald's is closed in the evenings now because they can't have staff to run the dining room. And yet we've managed to put 100 more people into these critical roles.
No, and the FTE increase is incredible.
It is. It's amazing. When we sat down and looked at the funding, we said, well, we might be able to afford 80, but we probably can't hire more than, 40. And here we are at 62 and almost 63. And this is amazing. And then looking at those specific types, community health workers, we increased that full-time equivalent staffing from about 7 to 46. That is just 5 times. That's huge. More people doing more important services, and mental health counselors and substance.
No, go ahead, Senator Lyons.
Yeah, no, I was just gonna go to the mental health counselors. Mental health counselors are so difficult to find. Yeah.
And we've seen some incredibly creative solutions from
Yes.
our offices saying, you know what, there's a mental health counseling master's degree program and they need their 2,000 hours. So we're going to bring them on board and a supervisor so that they can get their 2,000 hours and we can get someone in this practice to walk down the hall and say, you're in crisis. Let me get you some help today, not let me refer you out in 6 weeks.
Right. That's so critical. Good work.
Yeah. So this has provided 50% more staff to our community health.
So yesterday we had a group come in and thank us for what we did. Today we're thanking you for the work you've done.
Well, we thank all of our community partners.
Yeah.
Because they're the people who are doing it. We're just trying to make it possible. So thank everyone who has been involved in this project. So that's the staffing impact. And I love this picture because it shows the dramatic impact of where those 102 people are working. The dark blue is what we had before. The light blue is who's funded and who's paid for by that expansion. And you can just see those numbers moving to, well, where they need to be, frankly, moving to a place where we can really serve people. This graph, you'll notice, does not include, Dr. Soroya mentioned the Dulce program. In addition to these 102 individuals, there are also 6 family specialists working in the state with families of infants and young children. So we've also funded that. Unfortunately, 6 on a graph like this went from 0 to 6 would look tiny. So I didn't want to blow the scan. And so that is not there. But that also is happening in pediatric practices.
May I ask, are they regionally sort of dispersed?
They're dispersed. The practice has to opt into Dulce, and Dulce also includes some legal collaborations and some collaborations with the Parent-Child Center. So depending on what the practice has and the region's availability, I think we've got 2 in the Northeast Kingdom and a couple in Burlington, and there's
Upper Valley.
Upper Valley. That's the other.
Springfield and Windsor.
Right, none there. Yeah, so we had a hard time getting some areas. We went and said, would anyone like to participate? We were trying to disperse and we couldn't find any.
Are these just private practices or hospital affiliated?
So they can be a private practice, hospital affiliated practice, a federally qualified health center. Blueprint practices are all practices. Naturopaths are included. We don't discriminate. That is our goal.
No, there's much left in the way of private practice around here.
There's a little bit. We have not too much, no, but we have a little bit. So we're always happy when we can support them and they opt into expansion efforts too. So I throw this up because again, I'm a quant, I like numbers. This shows the percent increase in each health service area's community health team. And as you can see, it was more impactful in some areas than others. Springfield nearly doubled the size of their community health team. That's really impressive. Most places increased it by at least 50%. Randolph had a really hard time hiring the first year. And so they've just started to tick up a little bit. But even with that, they've still managed a 20% increase in staff. So that's still pretty good. Windsor, we did have a couple practices opt out. That's actually one of the locations where some of our practices chose not to participate. And that meant they weren't going to have the chance to expand. And St. John's story is a little funny because before the expansion, they had the second largest community health team in the state, despite not having the second largest health service area in the state. So a percentage increase for them is harder to achieve because they were already pretty big for the size of their health service area. But that gives you a chance to look and say, yes, this did stuff throughout the state. What else have we done? So that's kind of the big overview, who's working, how many more people are working, but what are they actually doing? So in the pilot, we did a pre and a post chart review. What is a chart review? Our quality improvement facilitators, our staff at practices go in, they pull charts at random and they say, okay, let's look and see what happened in 2023. Let's look and see what happened in 2024. And they were looking at 5 charts from each participating practices community health team. This resulted in quite a few charts. Because it is random, we didn't try to pull the same person from year to year. Also, privacy and things like that. We don't want to know too much about these people. And it lets us compare what types of services and screenings were provided. And there were enough of them that I can actually do statistical tests and see if these results are random or not random, and that's fun for me and hopefully for you. So let's take a look at some of the results we get. Screening impact. In 2023, about 91% of adults were screened for the domains we care about: substance use, mental health, social drivers of health. Those are our big domain. In the 2024 chart review, it was 98.5%. That was a statistically significant increase at a very high level. So what does statistically significant mean? It means how likely is it that if I pull another random sample of charts, I won't see this difference? And the answer is less than 1%. If I did this 1,000 times, one time would it be different? And we might not see an increase. So that means highly likely that this is real, not just a factor of like, oh, you pulled 5 different charts and now they all have different things. This is a real difference. And that is part of the big impact of the expansion, is now we're actually asking the questions. And if you don't ask the questions, you can't provide the help because you don't know what they need. So that's a big deal. Almost everyone is getting screened with the domain. Individual domains, of course, vary because sometimes we ask more questions about one thing or another. Here's what they look like. Depression is actually the only domain we did not see a statistically significant increase in. We did see an increase. I test for significance in individual domains at the 99% level. I don't want more than a 1% chance that this is not significant, that this isn't a real increase. And so because I was being kind of so sensitive in my tests, I can't say that was a real increase. That increase could have been random. The rest of them, all of them were significant, and all of them were actually very significant. So you'll see here that we're doing pretty good screening in some things and not so good screening in other things, but better than we were before. The bolded ones are the ones with the highest positivity rates of the people screened. If we didn't ask the question, I can't count whether or not they were going to be positive. But you'll notice a few of them, like the finances one, 58% of people screened had some financial concerns, whether it was, I don't know how to manage my money, I don't have a bank account, some financial concerns, but we're only screening 40% of people. So these are kind of flags that we're bringing up with our quality improvement facilitators, with our practice, is to try to say, okay, maybe we should ask more of these questions. Maybe this is some place we can focus and kind of improve these screening rates a little bit.
Adding one thing too, for example, I know I think with finances, at North Country Hospital, they actually used some of their own information to actually reintroduce some of those community supports to their patients in a more strong way that was pre-pandemic that had weakened. I'm not telling the story as well as I should, but people are actually acting on these results so that they can bring those community resources closer to patients, even in the very beginning of the pilot. We should probably try to wrap up so Susan has time to talk.
Yeah, absolutely.
I can't help myself
So
to
this
add
is
stories.
one of the things that I'm gonna touch on.
I have to go to money chairs.
Oh, okay.
So I'll leave a few minutes early so I get lunch.
So one of the things that Dr. Sorian was mentioning is what types of things are being done. So increases in the changes in which we see the services provided. Brief therapy, we mentioned that having, a mental health counselor on staff lets you do that right there. We saw a statistically significant increase in the number of patients who were receiving brief therapy. The proportion who had that when they had mental health needs, they were getting brief therapy. It went from about 45% to about 68%. And that's, again, significant increase. As Dr. Sorian was saying, we have seen an increase in provision of resources for those financial needs. People are asking the questions and saying, we can help you with that today. And I think it's important to note there were no decreases in the provision of any type of service. So we looked at a lot of things. Outreach, are you still calling patients? Are you still teaching them self-management skills, how to manage their own conditions? Yeah, they're still doing all those things and they're doing more of some of these important things. So I'm going to turn it back over to John and let him steal my thunder
I get the fun
for
part.
the fun
Thank you.
part. And that will be great.
So these are some quotes in relation specific to the staff hired by the expansion. So from a patient interview, it's like a good friend checking in and I can tell her what's going on and she can give me resources to handle whatever problems that I'm having. From a provider in one of the practices, this is a squeaky chair. And I'm a squirmy guy, so I'll try not to move around so much. Community health team has been a lifesaver for us. Having access to her skills has been invaluable to the pediatric team. From an interview with community health team, I also was able to expand my work to be with children as well, which was as a new therapist, I was curious figuring out where my specific population to work with would be. And so it was cool that I was able to dip toes in both adult primary and pediatric settings. And then a family and caregiver interview. It kind of makes it easier to do the caregiving. It's not as stressful knowing that I can reach out to the social worker and she will back me really on anything that I need help with. And if she doesn't know how to do it, then she'll make some phone calls and make sure that she can guide me on how to do certain things or just make sure that my family's needs are met. Addie and I get to read quotes that are collected from our contractor partner who does this research every Friday. And it's a very moving way to end the week. Our evaluation will continue. Dr. Armstrong is going to be looking at Medicaid specific claims that should be completed in spring of 2025, comparing claim amounts and types between 23 and 24 for Medicaid patients who visited practices where the expansion is live and going. My quotes were from Market Decisions Research that's interviewing patients, families, and caregivers for what we call qualitative evaluation. And then it will come out last because the information from insurance companies takes the longest, but then there is a quantitative evaluation that we're partnering with a contracted analytics group called Medicasoft to do. Thank you so much. I hope we didn't run too much into Susan's time, but I set our lines. If there's questions, we can have them emailed to us or people can ask me or you can, however you want.
We'll
Transition us.
definitely have you back in.
Okay.
This is a good intro and it's very helpful. And it will also be helpful as we move forward, looking at other parts of healthcare reform. It is significant to our healthcare environment. Very good. Thank you.
Thank you so much. Nice to meet you all.
Thank you. Senator Cummings needs to leave. I have a meeting. I'm gonna have to leave at 5, and I'm gonna leave Senator Rulich in charge. Sharing in charge. So Susan, thank you for being so efficient. You're here, you're on screen, and your slides are up, so welcome.
All right. Thank you very much for having me. I regret I'm not there in person, but I'll keep this brief because I know I'm the only thing standing between your break. So my name is Susan Ridson. I'm the Executive Director of Vermont Health First. We're an independent practice association. So we were formed in 2010 by a group of independent physicians, and our sole mission is to promote and foster the long-term success of independent healthcare practices throughout Vermont. We do have 62 primary care and specialty care practices located in 11 counties across Vermont. You'll see those highlighted in the map. And we have over 215 clinicians, 140 of those are physicians, and the remainder are nurse practitioners and physician assistants. We actually have more than that, but just the way we count our membership, that's the official number. And 124 of those are primary care clinicians caring for about 88,000 patients. And then we have 91 specialists offering, about 24 different specialty care services, everything from dermatology, cardiology, gastroenterology, reproductive services, and so forth. And you can see the whole list of our member practices at our practice directory listed there, linked there. And then I'll just point out that many of the specialists do many of their procedures at the Green Mountain Surgery Center. I know you heard a little bit about the center from Chair Foster, but it's well loved by patients and is actually recognized for the second year in a row by Newsweek as one of the best surgery centers in America, and it ranked number 5 in the Northeast. So there's really high quality option for care in Vermont. I just want to say briefly that the value of independent practices is quite high. You get a lot for your money, which is the very type of healthcare option we need more of in Vermont. And time again, both nationally and locally, it's been shown that independent practices provide very high quality care at a lower cost. Accessibility is usually quite good with shorter waiting times often than what you'll find with other options in the community. And these are physician-owned practices, so it's really physician-led care that's patient-centered, personalized, and responsive. And just having a robust independent practice network is good for patients. So they have different options for care. Not everybody wants to go to a big health system. Some do, and that's great, but some want the more intimate experience in an independent practice. Same for healthcare workers. It gives them another option of a healthcare place to work. So it makes Vermont more attractive to workers. And just having this network increases the overall healthcare system resiliency. So for example, if you have a hospital taken out by a cyber attack or something, you have other providers in the system who are able to keep on going and provide care. So everything doesn't come to a grinding halt. Our focus areas this year, I think we're all aware of the AHEAD model being signed, the agreement. So we have the bulk of our primary care practices were in the all-payer model, so they will lose funding at the end of 2025. So we're very concerned and want to make sure that those practices are properly supported when that model ends. Real concern for us. And then we're excited to work with this committee on certificate of need reform. I know you spoke a little bit about this with Chair Foster as well. We've shared our version of a bill with Madam Chair Lyons. And I want to thank Senator Gulick for shepherding our bill in which calls for an increase of the thresholds to $10 million across the board with no variation between hospital and non-hospital. We think the playing field really needs to be leveled there. I personally think that certificate of need reform is one of the reasons certificate of need is one of the reasons Vermont is in the situation it's in. Certificate of need has been associated with decreased access and increased costs, the very things we're struggling with. It's also a barrier to entry, particularly for non-hospital folks like those who tried to got the Green Mountain Surgery Center going. So we really need to level that playing field. And then sustainable reimbursement, I'm sure you've heard this from other entities, is a real problem. We need reimbursements that keep pace with the costs, just like the FQHCs. One of the huge crushing costs to our practices as well as the entire state is just the cost of healthcare insurance. And our reimbursements just aren't keeping pace with the increasing costs, and that's an issue. And it affects our ability to recruit, physicians into independent practice and nurses and techs and everything else. When our reimbursement is not keeping pace with expenses and as is at a lower level of some other entities as it is, it's really hard to compete. There are other barriers to workforce and recruitment that we face too, unique barriers. In the interest of time, I won't go into, but I welcome conversations with each and every one of you. Please reach out if you want to hear more about that. And then administrative burden is real. It's definitely a thing that affects all of our practices. Thanks to this committee and to House Healthcare for the work done with Act 111 on this. It's definitely a step in the right direction, but as Medicare Advantage increases, so does the admin burden. So it will continue to be an issue for practices. And here's how you can get in touch with us. Really welcome conversation. I'm really proud of our network and the great care that they provide Vermonters. And any questions? Thanks for your attention. Hopefully that wasn't too fast.
Thank you so much, Susan. Would you like to come in to testify on the CON bills?
Yes, absolutely.
That'll be great. Thank you so much.
Thank
you. For the new senators, I know Susan mentioned 111. Did you want to hear a little bit more about 111 from last session? Or
Yeah, I don't know what 111 is. Actually,
can you give us a real high level of what 111 was, Susan? It'd be great.
Sure. So Act 111 was a bill that worked to standardize some of the administrative burden that practices face. So it has some limitations around what an insurer, or at least a state regulated insurer, can do around prior authorizations, which is basically a permission slip for a patient to get a certain service that their doctor recommends. There's also limitations around medication step therapy and so forth. There's also this whole section on claims edit, which is, without getting too much in the weeds, it's basically a process that payers put into place. They often use artificial intelligence to look at a claim and say, does this make sense? And they couldn't even stop a claim from being paid. It's really complicated, actually. And it's like the Wild West. So we were trying to put some standardization around it and have the payers do similar claims edit that Medicare does. So we all know what the playing deck is. There's other components of that bill as well. It's a pretty big bill, but that's the high level.
Yeah, thank you, Susan. Yeah, we spent a lot of time, especially with the prior authorization.
Yes.
Just to make that a little less cumbersome. So great. All right. Well, do you guys have any questions for Susan? No? All right. Thank you so much, Susan. We'll be seeing you soon, I'm sure.
Okay, great. Thank you, everybody.
Yeah, bye.
Bye.
Okay, I think we are done for the day.